Welcome to a podcast brought to you by the American Academy of Orthopedic Manual Physical Therapists. Our academy is a national organization committed to excellence in orthopedic manual physical therapy practice, education, and research, and we're here to explore a wide range of topics with you through interviews with content experts.
Hello, my name is Stephen Shaffer, and I'm excited to bring to you another amazing interview from the 2021 AAOMPT conference. This time, our guests are Dr. Chris Schauerte, Dr. Christopher Hagan, and Dr. Alex Anderson. Dr. Schauerte holds both MSPT and DPT degrees, as well as a postgraduate MNIPS diploma, the latter of which she earned from the University of Otago in New Zealand. She also completed a fellowship at the University of Illinois at Chicago. Currently, she is an adjunct faculty instructor at Northwestern University and a mentor in the Northwestern University Fellowship in Advanced Orthopedic Physical Therapy Practice, Research, and Education. In addition, she practices outpatient orthopedics at NorthShore University HealthSystem in Glenview, Illinois. Dr. Hagan completed both a DPT and an orthopedic residency at Northwestern University. After that, he completed fellowship training at the University of Illinois at Chicago. Currently, Dr. Hagan is both a mentor for fellows in training and a contract educator for DPT students. He is also currently working towards his PhD in health sciences. Dr. Anderson is a board-certified clinical specialist in orthopedic physical therapy. After graduating, she completed fellowship training at the University of Illinois at Chicago. In addition, she holds a certification as a myofascial trigger point therapist. Currently, Dr. Anderson works full-time at the University of Illinois at Chicago and is the founder of her own private practice, the Physical Therapy Academy. In addition, she assists in lab instruction for physical therapy and medical students at the University of Illinois at Chicago, as well as fellows in training at Northwestern University. The presentation we are going to discuss today is entitled, The Things Left Unsaid: Adhesive Capsulitis as a Model for Improving Health Education and Wellness Advocacy. I've already had the pleasure of reviewing the content in this presentation, and, as you're likely aware, the conference has already come and gone. As a result, I know that this presentation was a hit. So, without any further delay, let's get to the interview. Dr. Schauerte, welcome to the podcast. How are you doing today?
I'm good. Thank you for having us.
Well, you said us, so let me go on to the next guest. Dr. Hagan, a warm welcome to you as well. How are you?
Doing great. How are you doing? Glad to be on here.
I am super well. And to our third guest, Dr. Anderson, welcome to the podcast. How are you?
Hi there. I'm doing great. Excited to talk about some nerdy PT stuff with you today.
Well, nerdy is what we do best. So let me state for the record, it's our pleasure to have the three of you on the show. Thank you for your contributions to the recently passed conference. And with that as our brief introduction, can you start us off by talking about the general prevalence and risk factors as they are known for adhesive capsulitis?
Yes, so I can take that question. Kind of a overarching definition of adhesive capsulitis is basically involving fibrosis of the glenohumeral joint with a chronic inflammatory response. So, looking at prevalence and risk factors for that, we see almost 5% of the population can be affected by this condition, with a dominant percentage in female. Almost 70% of adhesive capsulitis cases are female. The cases that are male end up being a little more at risk, meaning they are more predisposed to longer recovery and tend to report greater disability. Other risk factors would include a sedentary job, the non-dominant shoulder, and an age range greater than 40 years. On top of that, we can see diabetes and thyroid disease as systemic risk factors for this condition as well.
Dr. Hagan, thank you for that great answer. I know you've already partially mentioned it, but can we dive in a little bit more about the pathophysiology as it relates to adhesive capsulitis?
Yes, I will stay with you on that question as well. I think going back to the overarching definition of it being largely fibrosis from and chronic inflammatory response, I think is the basis for the pathophysiology of this condition. Getting a little more into the weeds, however, we can kind of look into, the matrix of the glenohumeral joint as far as changes that occur in those with adhesive capsulitis. We looked more into the matrix malleoproteins and the tissue inhibitor metalloproteases, sorry about that, which are known to regulate the remodeling of the extracellular matrix. And in those with primary adhesive capsulitis, it's been found that there is actually less production of the MMPs and a smaller ratio of these two proteinases versus controls. So I think when we see that, there's just not enough turnover in the matrix of this joint, including the underlying inflammatory response that's going on. And to add to that, I think one of the bigger factors or the bigger things that we should be thinking about clinically is this idea of neoinnervation and neoangiogenesis, being that it's also been shown that in the glenohumeral joint, there can be increased vascularity and even new nerve growth that's there. So, as clinicians, we should be aware of this pathophysiology when patients might be reporting severe pain, because there's actually been shown to be more blood flow there and additional nerve growth.
And to add to what Chris has already stated, Lubis and Lubis in 2013 did a study and compared the serum levels of those proteins that degrade the collagen, and found that the intensive stretching group in their study actually had improved serum levels and better ratios that favored collagen turnover versus the group that was in the supervised neglect group. So I think it helps point to, what we're doing is helping versus just sending the person off on their own, where they might not be kind of achieving some of that benefit of favoring changes in that extracellular matrix.
That's a great description. Thank you both for that. And let's take it a step further and tell me, how is the immune system involved when it comes to adhesive capsulitis?
So I can speak to that a little bit. It basically, I think sometimes as PTs, we lose sight of the fact that adhesive capsulitis is an immune modulated event. So immune changes in the tissues have been found in multiple studies. And I think when we think about the immune system, we have to think about that chronic inflammatory response that's going on. So those patients that have chronic inflammation are definitely at higher risk for adhesive capsulitis. And how the immune system and metabolic system are working together, I think sometimes we don't always think about on a clinical level as well. So they have found increased cytokines that produce synovitis. They found the cytokines in the glenohumeral joint, in the subacromial bursa, in that extracellular matrix. And the theory is that that's acting as the persistent stimulus that then leads to the capsular fibrosis. So lymphocytes, T lymphocytes, macrophages, mast cells, Hand et al. In 2007 found those in the rotator interval, which also suggests, an immune response for adhesive capsulitis. So part of our talk at AAOMPT was to try to get clinicians to think about how can we help our patients make some lifestyle changes to improve their immune system as well as their metabolic system, since that was likely the predisposing issue that led to them developing AC in the first place.
And I know that you've already partially taken a dive into this, but take that a bit further and tell me about the metabolic changes that are associated with adhesive capsulitis.
Well, there are several that have been found across multiple studies. I think the two that PTs most commonly think of is diabetes and thyroid dysfunction. But also independently associated with adhesive capsulitis are high levels of cholesterol, triglycerides. Patients with obesity are likely to have less of a good response to our interventions and more of a protracted course. Patients with metabolic syndrome, which can be the precursor sometimes to diabetes. All of those metabolic changes can be leading to that chronic inflammatory state and that increased cytokine production that is theorized to be putting people at risk for developing AC. And, one study I think that demonstrated the risk factors kind of enormously, as well as why we really were promoting in our talk about how PTs really need to be assuring that proper screening of these patients has happened, was by Tig and Oakley in 2008. They looked at 100 patients that had been diagnosed with AC, and they found that 72% of them had either diabetes or pre-diabetes. So, and of those 72%, half of them had no prior knowledge that they actually had a diabetic condition. So it points to how important it is for us not to just think about their shoulder, but to also look into their medical chart and assure that they have had screening for diabetes and that they, in fact, do not have diabetes at the time that they're being sent to us for adhesive capsulitis.
So this is great. You're taking everything one step further than the general level that I think the orthopedic manual physical therapist is accustomed to. And let's keep going forward on that theme. So we've talked about the immune system. We've talked about metabolism. Can you speak for a moment about central sensitization or nociplastic changes and how it relates to this diagnosis in particular?
I think some of the same inflammatory mediators, right, that are responsible or are present in central nociplastic changes also play a direct role in adhesive capsulitis. So we're talking like cytokines, neuropeptides, growth factors, neurotransmitters. And of course, as Dr. Hagan spoke to before, he touched on the neoinnervation and the neoangiogenesis. There's these whole changes that have been found in the capsule of the glenohumeral joint, and that can, I think, explain the severe pain in some of these patients. Adhesive capsulitis patients also demonstrate those changes, and especially during the highly irritable stages with hyperalgesia, sometimes allodynia, pain prior to resistance during passive ranges, on and on. And so I think we're also seeing some evidence that supports central nervous system focus interventions such as mirror therapy, 2-point sensory discrimination, laterality training. I think this is an area that we need to do a little bit more research on, and some of these studies are a little bit smaller, but as we are experienced in treating chronic pain patients that experience nociplastic changes, I think this is a really interesting topic, especially for those in the highly irritable stages.
And to piggyback off of that, I think it is something else that we can, provide for these patients when we think that, we can't touch their shoulder, it's too painful to move or range them or do anything. This provides another avenue to maybe manage them in an effective way. And, looking into central sensitization and these high irritability patients that go through the stages of adhesive capsulitis, there's a lot of overlap. And I think it's hard to rule out that there's something going on centrally with patients with this condition. And I think that if we can, I don't want to say put them in a box, but if we can pull from that to manage them, then I think that provides just a whole nother level in the clinic that we might be able to get some either pain relief or some improved mobility out of these patients when they're very painful and irritable.
And also helping them better understand the process and what's going on and maybe why their pain levels are so high. I still think PTs sometimes in the clinic struggle to really explain these concepts to their patients. So maybe talking about the inflammatory mediators and how the immune, metabolic, and central nervous system are all kind of overlapping might help them better understand the process that they're going through.
I couldn't agree more. These are all topics that I bring up with my patients all the time. Adhesive capsulitis, like many diagnoses, is a far, let's say, deeper and broader diagnosis than some people give it credit. In other words, it's not just a mechanical stiffness, but rather it's this systemic process. And speaking of which, can you dive a little bit into the role that you think diet can and or should play when it comes to managing a patient that has adhesive capsulitis?
Yes. So first, I just want to say that I was both excited to cover this section in the talk in the presentation at AAOMPT and a bit intimidated, which I think is how a lot of us feel as physical therapists. Our role in understanding diet and nutrition as it relates to any particular musculoskeletal health condition, I think is important. And I think, at least for me, this is an easy area to neglect. I'll consider the impacts of medication use and sleep and exercise and psychosocial factors before I think of diet. And that's including when my patient shows up in the clinic with their fried chicken and a large Pepsi. So it's not even that I don't consider it. I just never thought to express the effects it can have on a particular chronic pain condition. And something like adhesive capsulitis, where there is a clear correlation between underlying metabolic and systemic conditions, I think this is an area that we really need to touch on. So I learned a lot researching this for the presentation, and even just how nutrition relates to sleep. Excess sugar can cause wakeful cycles. What? Didn't know that. Low fiber and high saturated fat diets can cause decreased deep restorative sleep. So just some of these contributing factors as well. So I think knowing the reasons behind why this might be, eating, before bed isn't good because your body has to spend energy digesting rather than resting, makes sense. So I think explaining this to our patients can help them, give them some tools and some knowledge, and to kind of, encourage change. I think diet can also be a tricky conversation to start. It might be sensitive due to a patient's financial situation or uncomfortable because of their weight. So they might not be ready to make that change. So the tools that we discussed in our presentation, starting the conversation and the trans theoretical model, both were really helpful to know of and about and read through in order to, give that to our patients so that we can help make the changes appropriately, and a tool to even just bring that into the conversation. And then some of the other things that I learned is that really there's so much specific nutrition that can really affect people's pain and inflammation. There are foods considered to be immunonutrients, and some that have a profound effect on pain and inflammation. So hopefully for the physical therapists that did hear our talk, they're even more encouraged to make that referral to a nutritionist who can give expert advice and individualized advice to our patients.
Adding to what Alex has said, I think for PTs to remember, for those patients that might be in the pre-diabetic phase or have an elevated A1C or not be managing their diabetes well, just thinking about that high blood sugar in and of itself is pro-inflammatory. So I think we have to do a little bit better job to give them education both on exercise, which is completely in our PT realm, but I think sometimes with adhesive capsulitis, we get so focused around the shoulder that we forget to get them on just a good general exercise program. Since we know this is such a long continuum often that it can take for it to heal, it would be so good for all of the conditions that often these patients have to get them on a regular exercise program and to address diet. We're only helping them halfway if we don't mention or give them resources, or at least try to refer them potentially to a dietitian or a certified diabetic educator if they do have diabetes. We can give general great lifestyle advice around healthy diet, but if a patient has specific dietary needs, I think we also have to be the advocate for that patient, maybe back to the physician to refer them for specialized dietary advice as well.
I was just going to chime in and kind of say that I think it's important to think about the whole patient that's in front of us. And I didn't dive into all the details from our talk from a risk factor perspective, but those with diabetes are 5 times more likely to have adhesive capsulitis than someone who doesn't. And they have a up to 40% increased risk of developing this condition in their lifetime. So I think when we start to think outside of this patient just having a shoulder problem, it's very crucial to at least start the discussion about general exercise and diet and things that factor into maybe why they might be having diabetes or thyroid conditions on top of shoulder pain versus being so lens focused on their shoulder pain. So if we look at them as a whole patient, I think these things are very important to talk about in the clinic.
So obviously you're taking this in terms of the general conversation much further than just orthopedic manual physical therapy. So let's actually run with that and say, in addition to the physical therapist, what types of professionals are you considering bringing into the fold when it comes to successfully or thoroughly managing a patient that's been diagnosed with adhesive capsulitis?
In our presentation, we outlined different factors. We outlined systemic factors, intrinsic factors, and extrinsic factors. So part of our job as physical therapists is to screen out some of these things and in relation to adhesive capsulitis specifically. So I think when we include different providers, it's going to be different for each patient. That depends on our screening. We talk a lot about taking vitals. We started off with that, something that I think in the clinic, sadly, I've definitely worked in some clinics where it just wasn't happening. And I screen vitals on everyone that comes in our ortho clinic. I mean, we're going to exercise, for one thing. And then for another thing, you'll be surprised how many times you find hypertension in folks. So as we know, hypertension is associated with adhesive capsulitis. It's pro-inflammatory and it is part of the metabolic syndrome. This could be a potential reason to refer back to the primary care or monitor this, communicate with their primary care. I think that, we play a crucial role in this, and it doesn't start with the adhesive capsulitis patient. It starts with smaller steps and establishing relationships with various referring physicians. It's maybe a little bit easier in a big hospital affiliation where we have easier communication with EMR systems and such. But maybe you fax over the eval to the referring physician and write them a note or something. Obviously, we can't screen A1C ourselves, but we can certainly recommend it to the patient. Reach out again to the referring physician, know normal levels for this, and that it's a measurement that provides an estimate of blood glucose over the past 90 days. We can talk to our patients about it. We can ask about history of diabetes. So I think with a series of questions and understanding what contributes to adhesive capsulitis, I think our screening is going to be really big, and it'll help start a conversation with our patients and determine, what resources we need to connect them with and which providers we do need to contact for them.
Another factor that we haven't touched upon is that depression and anxiety are also risk factors for developing AC. So we talk about making sure that you're screening your patient for either depression and or anxiety. And since it is more common in this population, having that high on the radar and referring out for that as well. Because if you already have depression and anxiety, and then you're being told by your PT, oh, this chronic shoulder pain that you now have developed, this could take anywhere from a year to 2 years to resolve, they may be in need of additional resources just to deal with the chronic pain that sometimes we see coming with AC. So making sure that you're looking for and addressing the mental health aspects of their presentation as well.
That's a very thorough response, and I love it. Let's actually, in the wake of that answer, bring it back to what many people might consider the beginning, and that is, of course, we're AAOMPT, the American Academy of Orthopedic Manual Physical Therapists, and I haven't heard you yet once talk about manual therapy. I know we're taking it above and beyond today, but what role does manual therapy, if any role at all, have when it comes to trying to manage adhesive capsulitis?
So glad you asked that, Shaffer. It goes without saying that we are big believers in manual therapy. All three of us have been through fellowship training in manual therapy. Within the literature, we know there is evidence that joint mobilizations may be beneficial. but that it isn't superior to other interventions. We just wanted to really stress all the other aspects that may be overlooked when treating these patients. But certainly we want to consider the patient's irritability levels when considering if and what manual therapy technique we use. As mentioned previously, nociplastic changes can take place. And just like we may utilize manual therapy for patients with predominantly nociplastic type pain, I believe there is a place for it. The clinical practice guidelines do offer some advice on this as well. So low intensity joint mobilizations in pain-free accessory ranges and glenohumeral positions are recommended for those who are highly irritable. For those with more moderate pain levels, moderate intensity joint mobilizations, progressing amplitude and duration into tissue resistance without producing post-treatment tissue inflammation and pain is recommended. And then we can move into some end-range joint mobilization procedures. So high amplitude, longer duration into tissue resistance for those with a more low irritability category. I think what we really want to stress here is that we want to be reassessing our patients constantly when we apply any intervention, whether it's manual therapy or exercise. We want to use a multimodal approach, and we want to focus on restoring that shoulder range of motion for patients so that they can be more functional again. I think reassessment here is major key because it's going to change throughout the plan of care and throughout their course of adhesive capsulitis.
I think recognizing, as Alex pointed out, recognizing irritability and phase is just so key with these patients. So there is some evidence on the pathophys side that if they're in that high irritability state, being too aggressive with stretching, too aggressive with range of motion, too aggressive with potentially joint mobs, if they're in a highly irritable state, that actually could be adding to the mechanical stress on the fibroblasts, which then can promote the fibroblasts becoming myofibroblasts, which would promote further worsening of the capsulitis or capsular fibrosis. So that recognition of irritability is so key with your manual therapy. And I think I would give one shout out in preparing for this talk. Dueños et al. Had a great case series in JOSPT in 2019. They had some great techniques and nicely laid out pictures of manual therapy they found to be successful. And I would say personally, I've found a lot of those techniques to be helpful recently with my adhesive capsulitis patients. So would just give them a shout out for their great paper on that.
Well, thank you for establishing the fact that manual therapy is not gone by the wayside. But if I can reiterate everything that's been said here today, clearly we need to take this to the next step. And I'm fully and totally on board with taking our manual therapy practice and broadening it so that we can be the best clinicians possible. And if I can take this conversation to what might be an uncomfortable level, to my three guests, is the diagnosis adhesive capsulitis too simplistic? Should we rename the condition, or should we just keep running with this general idea that the problem lives in the shoulder?
I would say there are definitely a few papers out there that speak to how adhesive capsulitis is a misnomer, that there truly aren't adhesions. So it doesn't accurately reflect the fibrosis that's going on and the chronic inflammatory state. So there are definitely a lot of people out there who feel that it is not the greatest name or the most accurate name for the condition. And I also would say if we could possibly rename something often associated with adhesive capsulitis, it would be this concept of supervised neglect. I would love to see us more thinking about supervised recovery or supervised healing. I think that term neglect leads people to think you can just send someone off for several months and have them not doing anything. And I think that we need to rethink that concept of neglect and more towards supervised healing or recovery.
Yeah, I agree with Chris. Actually, the case series that she brought up by doing us in JOSPT mentioned the term frozen shoulder contracture syndrome as a potential name, just to give it kind of a better, I don't know, more all-encompassing sort of name. I think that might be something to consider, more of a syndrome, which might encourage, therapists to look at this more wholly and all of the complex interactions that are involved. So I don't know if the name matters so much. I think when you hear frozen shoulder or you hear adhesive capsulitis, and we all know we've all had that patient who it's frustrating. We can't seem to help them or get them better. And I think the point of our talk was to really just figure out, what are we missing? Is it diet? Is it exercise? Is it sleep? Is it mental health? Is it physical therapy? So I think we just want to broaden our thoughts on this and attack this at all angles if we can, and try to create a change.
And I would kind of agree with both Chris and Alex there. I don't know that it matters all too much what the diagnosis is called, but I guess I could say, maybe there could be a better name for it. Maybe at least adhesive capsulosis, since it's a little chronic inflammatory state. But and all kidding aside, I don't know what the name should be, but I think it's really important to think about the person as a whole that's coming in with this diagnosis. And I think we do that, or we should be doing that, for all of patients with all conditions. And that's why, as PTs, we could be the best advocate for them and pick up on what we think they need the most, and have that talk with them or give them that intervention. So it doesn't really come down to a label of a diagnosis, but I guess you do have to call it something, if we have to say that.
All of those points are great, and I'd love to dive into them more. However, it seems that we have run out of time. I'd like to thank each of you for joining us on the podcast today. It has been both fun and educational to have you in this conversation, and I hope our audience enjoyed this conversation as much as I did. I have no doubt that you'll continue to generate great work, so maybe we can hear from you in the future when there are advancements on this topic.
Thank you so much for hosting us today, Dr. Schaffer. We really appreciate that you reached out
Thank you.
and asked for this.
Yeah, it's been fun, and hopefully we can meet again and talk more about this with some more information. That would be great.
This has been a production of the American Academy of Orthopedic Manual Physical Therapists. You can learn more about the Academy by visiting our website at AAOMPT.org. You can also find us on Facebook, Twitter, and Instagram by searching for our acronym, AAOMPT. The views and opinions expressed on the AAOMPT podcast are those of the interviewers and interviewees and do not represent the official position of AAOMPT. The information presented should not be used as personal healthcare or clinical practice advice. If you need to find an expert orthopedic physical therapist near you, then check out the Find a Fellow feature under the Public Resources tab at www.aaompt.org, which you can find in the show notes.